that transforming the health ecosystem holds the potential for the greatest impact on citizen welfare, driving social progress, technological advancement, and sustainability. Our overarching goal remains clear: insurance for all by 2047. Last year, at the Raksha Summit 2024, we framed our action agenda with the Borderless Health Report. This vision sought to transcend traditional barriers, be they geographical, institutional, or conventional methods of care delivery. This is to ensure that every citizen could access relevant care packages seamlessly across the country. Now, to achieve this sweeping vision, we identified the foundational digital architecture necessary for such a transformation, the Health JAM Trinity. J stands for Joint Health Data, and this infrastructure, created by integrating the ABHA, Ayushman Bharat Digital Mission, Electronic Health Records Standards, and the National Health Claim Exchange, creates a unified, consent-based digital backbone that connects patients, providers, and insurers. This architecture is crucial as fragmented data has historically bred inefficiencies and systematic opacity, leading to misrepresentation and document manipulation. The A stands for automation, leveraging the fast pace of adoption of AI and Gen AI technologies. And automation drives transformative shifts, including claims assessment, personalized packages, sharper pricing, and the real-time fraud detection. And finally, the M stands for mobile-enabled services. Mobile technology is the great leveler, enabling access for all, overcoming geographic barriers, and delivering connected care journeys to citizens through self-serve options and real-time claim tracking. Successful scaling of the JAM Trinity is foundational, and it provides the transparency, accountability, and the digital rail system necessary to support our universal coverage ambitions as a country. And of course, as we celebrate the momentum driven by Viksit Bharat, where the health insurance gross written premiums are projected to reach almost 3 lakh crores by 2030, we must confront the systemic challenges that threaten to undermine our progress and erode the public trust we seek to build. So this year, Raksha Summit 2025, while continuing to stress on improving on the JAM foundation, focuses very intensely on 3 key stressors that are pressing our health ecosystem. One is medical inflation, with India's healthcare inflation averaging around 12 to 14% year on year over the past 5 years, outpacing general inflation significantly. And 2 is out-of-pocket expenditure. India's out-of-pocket expenditure still stands at a high 39% of the total health expenditure, leaving households bearing a massive financial burden due to underinsurance. Finally, the third, the fraud, waste, and abuse, the silent and systemic challenge that fuels the other 2 stressors. So it was with this thought that the 2025 summit focused exclusively on combating fraud, waste, and abuse in the health insurance in India. And our knowledge report, which will be unveiled later part of the event, prepared by partners BCG, dives deep into these causes, implications, and solutions. The report will also lay a roadmap to implement prevention, detection, and deterrence at scale to combat fraud, waste, and abuse. Let us all work together to make health insurance the financial and ethical backbone of Viksit Bharat 2047. I thank you all once again for being here, and I look forward to all the insightful discussions that are ahead. And as the session progresses, you will hear more about borderless health, combating FWA, improving experience using technology and data. And of course, as MediAssist and the audience, we look forward to learning from each of the speakers and putting some of these in action. In fact, I think it's important for us to come back and tell you that we took away some of these actions, call to actions from the last year, and attempted implementing some of these at MediAssist. We've implemented initial attempts at using AI to combat FWA, saving over 400 crores to the insurers the last financial year. We've implemented mechanisms to keep the patient out of the loop, improve their discharge experience at the hospital. Patients a month walk out of the hospitals even before bills are generated. We are no longer talking about speed, we are actually talking about reimagining experience. And in fact, this morning we relaunched our commitment to deploy all of the technology at our disposal as reusable components to the entire industry, with the vision that the providers would be able to safely take calls and which will be corroborated by insurers. And all of this happening through AI platforms and letting at least 1 in 2 patients walk out of the hospitals without waiting for the famous cashless approval. And I look forward to such inspiration again from this year's session that we can take back, then come back and report next year. And we have a distinguished lineup of a keynote speaker, a guest of honor, panelists, and jury members for the day. Before I sign off and hand you over to the next segment, it is my honor and privilege to introduce 2 of our guests today. Our guest of honor, Mr. Sivasubramanian Raman, Chairperson, Pension Fund Regulatory and Development Authority. Mr. Raman served as an officer of the Indian Audit and Account Service from the 91 batch. And some of his previous stints include the Deputy Comptroller and Auditor General and CTO in the Office of Comptroller and Auditor General of India. And he's held several leadership positions in the past, including Chairman and Managing Director of Small Industries Development Bank of India, Managing Director of NESL, Executive Director of the Securities and Exchange Board of India. He holds a bachelor's degree in economics, followed by an MBA from the University of Delhi. And his list of degrees is so long, so it's going to take me a minute. So amongst his professional and academic qualifications are an MSc in Financial Regulation from the London School of Economics and Political Science, LLB, CDO, Chief Digital Officer Certification from the Indian School of Business, the Certified Internal Auditor credentials from the Institute of Internal Auditors, Florida, and a postgraduate diploma in securities law. Thank you so much, sir. It's our honor and privilege to have you here in the audience. And before I call on our keynote speaker, Mr. Kasim Kutay is the Chief Executive Officer of Novo Holdings Denmark, a position he's held since September 1st, 2016. In addition, Mr. Kasim is a member of the Board of Directors of Novo Nordisk and Novo Nordisk. From 2009 to 16, Mr. Kasim was a partner and member of the Global Management Committees of Moelis & Co. From 1989 to 2007, he held a number of positions at Morgan Stanley, including chair of the European Healthcare Group. Mr. Kasim was member of the Board of Trustees of Northwick Park Institute for Medical Research UK, and he was also a member of the Board of Governors previously, and the Investment Committee of the School of Oriental and African Studies UK. He's a co-chair of the board of CW+, which is a Chelsea and Westminster Hospital NHS Foundation Trust. At Chelsea and Westminster Hospital, Kasim has championed the launch of Best for You, a dedicated center for the treatment of adolescents in mental health crisis. Kasim is a UK national and holds MSc and BSc in economics and from the LSE, which is London School of Economics and Political Science. Sir, it's our honor to have you amidst us today. Please may I request you to come on stage and give us a few of your remarks. Right. Thank you so much. Thank you, all the best.
Okay. Good afternoon, and thank you very much for that very kind and warm introduction. Ladies and gentlemen, it gives me great pleasure to be with you here today. I'm Kasim Kutay, the CEO of Novo Holdings, the entity that manages assets and wealth of the Novo Nordisk Foundation, which today ranks as one of the largest foundations in the world. In addition to being the controlling shareholder of Novo Nordisk, and I'm sure you've all heard of Ozempic and Wegovy and the new generation of diabetes and obesity products, the GLP-1s. Novo Holdings is among the world-leading investors in healthcare, and I'm delighted that we recently opened our office in Mumbai, literally just a few months ago, and I'm joined here today by my colleague and partner, Amit Kakkar. Where's Amit? Put your hand up, Amit. Among our investments in India are the hospital groups Medanta and Manipal, the diagnostics company MedGenome, and of course, the star of our portfolio, MediAssist. Vikram, thank you for your friendship, thank you for your partnership, and thank you very much for giving me the opportunity to speak here today. Today I will address a topic that's very dear to my heart, which is preventive health. I will also talk about what the Novo Nordisk Foundation, which is the 100% owner of Novo Holdings, is doing in the area of prevention in India. Despite the many challenges ahead, if we take the long-term view, there is cause for optimism. I believe that India is well positioned to make great strides in better health equity, in saving lives, in improving the quality of life, and importantly, in easing the financial and societal burden on society by rebalancing its focus to prevention. As a Novo Group, we have put our money where our mouth is and have demonstrated our optimism and belief that India can be a healthcare role model through the extensive activities that our foundation is undertaking in India. Delhi, in fact, was the first office that our foundation opened outside of Denmark, and is underpinned by a belief that there is government focus and governmental and non-governmental that are working to take India to the next level. Let me start by highlighting the biggest healthcare challenge facing India. With no exaggeration, I would call it a ticking time bomb. Most of you will not be surprised to hear that I'm referring to the significant and growing and the inequalities in the prevention and treatment of NCDs. Today, NCDs are the major cause of global mortality. According to the WHO, 66% of deaths in India are due to NCDs, most of which are preventable. There are approximately 90 million people in India living with diabetes, and that number is projected to reach 160 million people by 2050. In India, this is a staggering number. Over 70% of the urban population is either overweight or obese. It's very important to note that NCDs come with a host of highly expensive to treat complications and comorbidities. For example, diabetes is, among many other things, often linked to kidney disease and dialysis. Diabetes, believe it or not, is also implicated in tuberculosis. A large segment of the population in India have latent tuberculosis, and it only manifests itself when the body and the immune system is challenged by other conditions. Obesity, the comorbidities include diabetes, hypertension, cancer, and I can go on and on. If left unchecked, the ultimate treatment burden of NCDs will overwhelm your healthcare system, and the financial, I think. Now is the time to get in front of this issue with urgency and focus on primary and secondary prevention. It should come as no surprise to this audience that healthcare systems that are oriented to primary care are more cost efficient, have improved population health, and greater health equity compared to systems based on hospital care. When we talk of primary prevention, we are talking about preventing the onset of disease. In the case of communicable diseases, vaccines has, of course, done the job for us. Therefore, NCDs, non-communicable diseases, prevention of NCDs is the big challenge of today. Secondary prevention is the early detection that allows early intervention that increases the success of treatment or significantly delays progression. In the West and back home, prevention. We have systems that are geared towards treatment rather than prevention. Today, in my book, the and perspective, given the incredible advances in our ability to detect diseases earlier and more accurately. And this is, of course, combined with significant advances in treatment options for the disease that's diagnosed. While primary prevention is behind where it should be in certain OECD countries, notably in the UK, where diet and food labeling continues to lag, in India, we are way behind. From today's vantage point, if India as a country wants to manage its healthcare financial burden, equitably improve the quality of life and save lives, you need to double down on primary prevention. And the reason I say double down is I don't want to ignore the significant strides that have already been made. To be clear, the National Health Mission in India is focused on prevention. For example, India has in place a national clean air program with a focus on 131 cities. Let's now turn to the vices, for want of a better term, that need to be managed to get any society to win the primary prevention battle. You will not be surprised to hear that the culprits are tobacco, air pollution, alcohol, poor diet, and lack of physical exercise. Today, I'm going to focus on two of these issues, diet and pollution. Probably the quickest way to improve the long-term health of any society is diet. The US has finally caught up with this. You've all heard of MAGA, now we have MAHA, Make America Healthy Again, which is rightly focused on nutrition-based preventive care. Trans fatty acids, excess carbohydrates, salts, these are silent killers. Just shifting from processed to whole grain bread has demonstrated time and again the profound impact on diabetes, obesity, and other NCDs. Let me make this as clear as I can. Low whole grain consumption is the leading modifiable risk for cardiometabolic disease in India and globally. Unfortunately, despite laudable initiatives such as the Millet Mission, India is moving in the wrong direction. Consumption of ultra-processed foods is growing at an alarming rate. As an aside, we should note that historically Indian food was much healthier. For example, India used to use mustard oil, very healthy. The cooking oils of today are a major cause of heart disease. The solution is not easy. You ultimately have to deal with sensitive political issues. The key constituents, among others, a very powerful group. I also appreciate that from a societal welfare perspective, imposing taxes on unhealthy foods, as is done with tobacco, may for now be impractical for India. But it should be noted that countries ranging from Mexico to Norway to Hungary have on sugary drinks, salty snacks, and high-fat products. These taxes serve not only to reduce consumption, but also to allow for more funds to be spent on other preventative measures. At a minimum, India should start considering a major campaign to raise awareness of the link between NCDs and diet. And this should go hand in hand with a comprehensive food labeling program. India is way behind on food labeling. The good news is there are precedents to learn from. Food labeling measures have been implemented with much success in many countries. In Chile, for example, of all places, there has been a pioneering effort in this area, and they use black hexagonal warning labels on products high in sugar, sodium, saturated fats, and calories. They also restrict the consumption of these products in schools. Now let's turn to another major issue in India, pollution. Among the 40 most polluted cities in the world, 37 are in South Asia. And yes, Delhi is very high up on that list. According to the WHO, life expectancy increases by over 5 years if its guidelines on air quality are followed. With respect to industrial pollution, the issue in India is not so much the lack of regulation, but enforceability. There is just way too much unprocessed, unfiltered pollution entering the air and our waters. And of course, I don't need to go into the crop burning that happens around this time and heavily pollutes the air quality in Delhi. Construction, where the process of brick burning is a major pollutant with almost zero control on emissions. Just think if there was some form of a subsidy or incentive for farmers to, rather than burn crops, take them to a central unit where they can be disposed of and indeed recycled for better use, willpower, and investment. Unless regulatory enforceability is zealously pursued, lung cancer, heart disease, asthma rates will continue to rise at an alarming rate. The role model in South Asia in pollution control, particularly in the urban setting, is Sri Lanka, and there is much to learn from their success. I'd now like to shift to secondary prevention, where I think the opportunity in India is immense. Detecting disease early has never been more relevant. This is because our therapeutic options on interventions today are a true wonder of science. Detecting diabetes or hypertension early today means saving millions of lives, minimum significantly improving life expectancy and the quality of life. The long-term savings to the nation would be immense, so we must view the large adoption expense as something with a great return on investment. The low-lying fruit prevention is the very simple and quick, what I call add-on examination. Any interaction with a patient visiting a primary health facility should include quick and simple examinations to detect diabetes, obesity, hypertension, and so on. In many of the cases where a positive diagnosis is the output, there's not even a need for a referral to a clinic or a hospital, given the efficacy and quality of modern medicine. Referrals, as we all know, can be very problematic, given that for most rural Indians, health centers are inaccessible. Today, online consultations and healthcare apps are a viable alternative to referrals. And a very cheap pill called metformin is still the first-line treatment for diabetes or pre-diabetes if diagnosed early enough. And telehealth can deal with the medication's suitability for a patient and for the dispensing of the medicine. There are three major challenges in broadening secondary prevention in India. One is the lack of healthcare workers. Two is the training of workers in remote areas to do these quick add-on tests that I referred to. And three is the large number of people living in very remote locations. There are two, both of which the Novo Nordisk Foundation is spending significant time and money on in India. In 2020, partnership for education of healthcare professionals. And it is exactly what secondary prevention is all about, namely to equip the healthcare professional to provide quality prevention. The focus of the foundation is on current and future nurses who, as we all know, are often the entry point for any patient interface. We are working with Indian institutions to enhance the ability of nurses to quickly and efficiently detect the most common NCDs in patients. Among the institutions that the foundations are working with are CMC, or Christian Medical College, All India Institute of Medical Science, and the Public Health Foundation of India. The education prevention that we are providing these nurses is both physical, where they can attend classrooms and lectures, but it is also supported by a host of online training programs for the nurses that are in remote areas. In addition to training healthcare professionals as what I would call prevention agents, technology will improve access and health equity, which I know is a major focus of this summit. We must relentlessly invest in telemedicine, telehealth, support e-pharmacies, and grow the fleet of mobile units that can visit the most remote parts of the country. All these elements will partly solve for the healthcare worker issue. On technology, of course, we must also mention AI. AI diagnostic machines with less manpower. Let me give you an example. Novo Holdings is an investor in an Indian company called Cure AI, which is a world leader in AI-enabled X-ray diagnosis. A Cure AI system can take an infinite number of patient X-rays in a particular location and send that X-ray to particularly where a nodule or other marker has been found or identified, to a central location where a radiologist can then review the image and advise on next steps. So, let me close, because I think I've probably rambled on for far too long. As I said at the beginning, for better and more equitable health in India, and I do want to conclude with that. With the right focus, investment, and public-private partnerships, I truly believe that India is on the cusp of a major advance in primary prevention, the concomitant benefits to human life and the socio-economic benefits of avoiding late-stage and acute non-communicable diseases.
Mr. Kote, may I request you? Thank you. Thank you, and thank you for the truly insightful session. Ladies and gentlemen, we now move to a very special part of this evening. We are delighted to launch the BCG report titled Rebuilding Trust, Combating Fraud, Waste and Abuse in India's Health Insurance Ecosystem. A report that comes at a pivotal time for our industry and speaks directly to the urgent need for transparency, efficiency, and renewed confidence. To do the honors, may I invite our guest of honor, Mr. Sivasubramanian Raman, Chairman of PFRDA, to kindly join us on stage. Sir, may I please request you on stage? May I please have the BCG core team and MediAssist core team who has worked on the report on stage, please? May I request the copies of the report? So may I please request you to unveil and a photo up there, please. Thank you. Doc. May I just request you to felicitate Mr. Raman and Mr. Kuday, please. May I have the... Please. No problem. Thank you, gentlemen. Thank you. Continuing the momentum, we now move on into our first panel of the afternoon, a topic that stands at the very heart of healthcare administration today, as we've been speaking. Fraud, waste, and abuse in healthcare isn't a series of small leaks. It's a systematic threat at the heart of India's affordability and access crisis. It inflates costs, erodes trust, drains precious resources, and risks undermining the promise of Ayushman Bharat and universal health coverage. But tackling FWA, or fraud, waste, and abuse, is also one of India's most powerful opportunities. By closing leakages, we can stabilize premiums, expand coverage, and build a transparent, ethical, and financially resilient insurance ecosystem. Fraud resilience, data-driven health system can only protect citizens, but not only protect citizens, but fuels innovation, inclusion, and long-term national reform. It is a national mission central to Viksit Bharat 2047. Their integrity drives affordability, affordability expands access, and access strengthens a healthier, more equitable India. The session will explore how data, analytics, and collaboration can power smarter prediction, better pricing, and proactive prevention at scale. We have a power-packed panel today with us today, and while the teams are setting up, I would go ahead and introduce the first panelist. Joining us is Mr. Vipin Kumar Singh, Director at the National Health Authority and the leader of India's National Anti-Fraud Unit, driving critical work in fraud control and digital governance. Sir, may I have you on stage, please? We're also honored to have Mr. Sanjay Joshi, Chairman and MD of Oriental Insurance, bringing over 3 decades of deep industry leadership. Sir, may I please have you on stage? From the provider side, we welcome Mr. Dilip Jose, MD and CEO of Manipal Hospitals, a transformative leader with vast experience across healthcare delivery. Is Mr. Anand Roy, MD and CEO of Star Health, known for scaling innovation and customer-centric growth nationwide. Thank you. And completing our panel is Mr. Karthik Narayanaswamy, partner and head of India at Nova Holdings, bringing global investment expertise and sharp market insight. Leading this conversation is our moderator, Dr. Kiran Sombanshi, journalist, author, professor. Thank you. Over to you, Kiran.
Thank you. Thank you, Raksha Summit. Thank you, Shivani, for the wonderful introductions. It's an interesting panel, so to say, because it's very rare to find different stakeholder groups in healthcare coming on the same platform in a cordial setting. So it's actually a rare one. So to start with, your introductions have happened. So we have right from the government, we have insurance, we have hospitals, we have investors all coming together on the same platform. The issue is something which we all grapple with, as patients, as stakeholders in the industry. It's fraud, waste, and abuse. And it's something that is taking away almost 15 to 20% of the healthcare expenditure in India. Could be higher for different unorganized sectors even. So the one thing is how do you kind of look at it? How big is the scale? And are there any ways to kind of handle it better? And besides FWA, we also have a big issue of, as patients, definitely we feel that is medical inflation, the pricing part of it. While India is great, very affordable globally, a lot of outsiders are coming to India to, seek healthcare at a price and at a quality which is incomparable. But for Indians, we are seeing here that healthcare costs are going up. Medical inflation is double the rate of our general inflation. And if it goes on, definitely we will be soon kind of feeling the pinch very badly. So these two are the major issues that most of us face when dealing with healthcare. And since we have the who's who of healthcare industry over here, my question to all of you would be, to start with, would be, how do you see, how big is the scale of fraud, waste, and abuse from your respective perspective in the industry? So if we can, each one of you, please, deliberate on this.
So, good afternoon, everyone. Our estimates that up to 15% transactions in healthcare industry are associated with fraud and abuse in one way or another. If we specifically talk about PMJY ecosystem, it is around 0.8%, which we have saved by rejecting the fraudulent or suspicious claims, amount-wise. And if we take state variation, it varies from 0.5% to up to 2% of total expenditure.
And how does the government see it? Like, how does a national health authority see it in terms of combating it or looking at it?
So, ma'am, fraud is evolving, in healthcare particularly, is an evolving field. And at NHA we see mostly, the National Anti-Fraud Unit does not have any physical footprint all over India. It is all digital. So our role, basically we are adopting technology, AI, ML, devising new monitoring points, analyzing the cases. So during initial years, if you see, the mostly analysis was descriptive analytics. So we started in 2018 or something when the scheme was launched. Some 6-7 triggers were there. Triggers we call monitoring points basically. And those were basically monitoring the deviation from standard treatment guidelines which have been developed under PMJY. We talk today, we have more than 60 triggers. more than 80% use AI and ML. Their efficacy, I mean, the conversion fraud by states is approximately 50%.
Okay.
And that is how technology has improved the anti-fraud activities under PMJY.
It reminds me of a anecdote, personal thing, that last year my father was hospitalized, old age ailment, and when he was discharged, a week after that, I received a call from the TPA, asking me about the veracity of the claim and the patient name, where is he from, how am I related to the patient, and things like that. And that was the first time I realized personally, how fraud detection kind of works, and how bad the situation could be for them to actually personally call up patients and verify all the details of the claim. So I understand that these could be the numbers very much at play. Mr. Singh, coming to you, how is it, Mr. Joshi, at a public sector insurance company, how do you see it? Because insurance companies are always alleging and always complaining about the instances of fraud, and how do you kind of see that on a day-to-day basis?
It is correct. I agree with my co-panelists that it is to the extent of around 15%. That is the widely agreed number. And it has two components. One is fraud and one is abuse. Lot of wastage is happening in form of exaggerations, exaggerated over-treatment, or treatment which is actually not desired at all. Abuse of the system. At public sector insurance companies, as you know, these were the pioneers of health insurance. These companies were the pioneers of health insurance in India. So initially, when it was launched, it was a very limited coverage. And with the times, it kept on evolving, improving. Initially, it used to cover everything. There was a single sum insured where everything was paid. Going forward, when it was found that a lot of wastage is happening and the costs are going up, so it was thought of bringing in controls in forms of some limits, sub-limits, caps, etc. But later on, when the competition came, so it was also decided to actually the network providers also evolved, and the market also. So I am a bit digressing, so I will come back to the subject. So here what happened, initially the quality of underwriting, etc., or the controls were not that good. But later on, when initial passed, suddenly we found that the costs are constantly going up. And then we found this angle. And now currently the situation is that there are organized players in the market who have mastered how to use this system to their benefit. And as initially it took some time to identify them, but now that we have found the mechanism, and we have created our own ability in all the companies. And I will like to actually give credit to competition also, which actually started it earlier than the public sector insurance companies. Maybe we started late, but I can assure you that now we are equally aware and equally prepared. So these technological innovations which have come in, see, he mentioned triggers, fraud triggers. As we started to build up our data in a cohesive manner, initially we had data, but we were not knowing what to do with it. Now we are using that data. We have the longest experience, so we are using that experience. We have collaborators. We are mostly operating through third-party administrators or medical benefit administrators. They have also helped in bringing in a lot of efficiencies. So with all this, and now because very good quality data in a very systemic form, and then protocols have also developed. And one great thing which is happening currently is that the collaboration which is now happening. Collaboration is actually originating within the companies also. All the competitors who are competing in the market, but on this front, everybody has come together and are taking industry initiatives to curb the frauds. But everyone is worried about the spiraling costs. And the regulator is also actively promoting it, and the government is also trying to facilitate it. So many initiatives like NHCX or IIB or common empanelment initiatives or technological innovation adoption by the companies, AI, ML, all those things. So this is coming in, and hopefully we will very soon be able to find a solution for at least a fraud. And with the industry collaboration, we will also find a solution for
So you represent the India's largest private sector healthcare provider, and on this panel, you are the only one representing the healthcare, the hospital side. How do you see it? Because at the end of the day, for the patient, it is the hospital where the patient is going and paying the bills. So how do you see frauds, waste, abuse? Is it emanating from there, or how do hospitals kind of tackle it?
Thank you, Kiran, and thank you, Vikram, for having me here. Yes, it does feel a little lonely to be on this dais at this point. It is, and I'm comforted by seeing Dr. Raghuvanshi sitting there across here. I have another provider here. I do appreciate that the insurance companies face the issues of fraud and waste and abuse. I think it should be sort of irresponsible for me to say that it is not visible in the sector. But what I would want to sort of offer us an opportunity for us to work together would be, one is that there are 50 or 60,000 healthcare establishments in the country. Maybe 18,000 are empaneled with the insurance companies. I think with the data that the insurance companies talk about, maybe one option is to look at having a scoring system of providers that, looking at the data, who are the trusted providers, so to speak, where you do not have concern of fraud, waste, or abuse. That, from a insurer's perspective. And, Satish earlier talked about a fast discharge scheme. In fact, between MediAssist and Manipal, we operate it across many of our hospitals. We call it Raksha. When the discharge is announced by the doctor, the patient just walks out of the hospital. Just to settle between the TPA and the provider, because there is a comfort that this provider can be trusted. So I'm sure this is a mechanism or a model which can be replicated to the larger provider system. Second thing is, wherever possible, that if you are able to have a care pathway, an algorithm about how a patient is to be treated, a patient with certain presenting conditions, how the patient is to be treated, or how the patient's journey ought to be through the hospital, then that takes away some of the concerns of overuse or overprescription and all that. The third thing I would say is that audit. If there is transparency in the billing, for example, in the Manipal system, there is itemized billing available. While there's an overall summary, the group billings is available. Below that, every item that is charged to a patient is available. Now, if there are audits which are mutually conducted, and based on that, if corrections are required, that's another way of tackling fraud, waste, and abuse. My point is, it is a fact. I don't think we can wish it away. That it's a large ecosystem, and unless we start making an attempt at one end and try to address it from a protocol basis or a system-driven basis, we would only be talking about episodic instances that, and in the current rather antagonistic environment that exists, that, between providers and payers and in fact patients, I think unless we approach it systemically, we would only be talking anecdotally, which is not going to solve anything.
But among all three, like what do you see the more the instance? Is it fraud, is it waste, or is it abuse?
I would think as far as fraud is concerned, I would say it is a patient or an insurance beneficiary who's not reporting a pre-existing disease or getting insurance under false pretense could be a fraud, which I think my insurance colleagues would be better able to say. From a provider's point of view, fraud would mean you charge for something which you have not done. You charge for a procedure you have not done, a medicine you have not administered. I would imagine there would be instances of that, but I'm not sure if the organized sector or the larger corporates are the ones who would perpetrate that, So therefore, again, I will go back to the data that, all the data which is available, we should use it to sort of bring out the culprits, and name and shame if that is required. I think use the data in a manner which would identify. And is it a random incident or is it something which is a trend that you would see? I think AI and other mechanism would give us that opportunity and then give a score. Like all of us got CIBIL scores, right? All of us got CIBIL scores, which gives us a credit worthiness. And hospitals have an equivalent score from an insurer saying that this is a trusted provider. Those are the kind of mechanisms I'm talking about. Attempt to solve it at a system level and not at an episodic level.
Right. Mr. Roy, coming to you. Representing the largest, standalone insurance, private sector insurance company, how do you look at this fraud, abuse, and waste? In the sense that on a day-to-day basis, when the claims are coming to you, rejections are always a complaint by the patients. How do you look at that? Which is exactly FWA category, and do you really go back to the hospitals, and how do you kind of work around that?
Yeah, thank you so much for having me, and good evening to all of you. Thank you, Dr. Vikram, for bringing me to an interesting panel, which is something that we grapple with every day. If I kind of, in the picking order of why health insurance has not penetrated enough in the country, I would rank fraud, waste, and abuse as the number one. Okay, because this leads to two kinds of things. One is we have already spoken about the financial loss. My colleague spoke about 10 to 15% of insurance claims are lost to frauds every year. That is kind of anecdotal number. But even if you think about it, if 3 lakh crores is going to be the health insurance premiums in few years' time, and if 10% of that is lost to frauds, somebody is making 30,000 crores out of this industry, which ideally they should not have made, and ideally that should have gone to the consumers in terms of lowered premiums. I think that's the extent of this problem that we are dealing with. But larger than the financial loss, I think it's about which it is creating between all the stakeholders, whether it is insurance companies, the providers, the policy holders, and so on and so forth. You spoke about your own father's experience, So what fraud, this kind of the episodes of frauds leads to is that insurance companies tend to become more nuanced and more careful or cautious while dealing with claims, and they tend to look at everything with a stained glass and try to figure out if this is a fraud or if this is not a fraud. Thankfully, now with AI and with technology, we are able to deal with this in a much better manner. But 10 years ago, 5 years ago, this was a very, very difficult manual process. Every customer would be looked at suspiciously. If it was let's say a close proximity claim, in our parlance, that is, let's say if a claim comes within buying the policy, every customer would be looked upon suspiciously. So I think slowly technology is changing all of this. But to elaborate a bit, this fraud, waste, and abuse, if you look at frauds by itself, there are hard frauds and there are soft frauds. As Dilip mentioned, this happens across different levels of, stakeholders. It's not only providers, it is the customers. Sometimes it is an organized kind of a crime happening in various pockets of the country, about insurance frauds. So hard frauds are typically, there is no patient, there is no customer, there is but the bill is generated and sent to the insurance company for payment. Or as he mentioned, there's no treatment given, and at the provider level, sometimes, there are some categories of providers who indulge in this. But I think the solution to that is creating some kind of a database. The insurance, IIB is working on it, all the insurance companies are collaborating so that, there can be sharing of information. And these kind of elements can be eliminated from the population of insurance. So I think just like the banking sector has so successfully done in creating credit bureaus and so, I think it's time that insurance companies come together for this. End of the day, I think in a country like India with a population of our size, health insurance is something like a necessity. It's no more an option. And the government of the day is also giving the signals by waiving 18% GST on retail health insurance that this is the tailwind that is needed for more and more people to get covered under health insurance. But unless this evil of fraud is eliminated to a large extent, I think the trust deficit will remain. So eliminating frauds by creating credit bureaus, by hopefully of some kind of regulatory oversight over the providers needs to be brought in, because insurance companies and PPAs are tightly regulated, whereas the providers are self-regulated, so to speak. And then there are, various levels of governance standards across that. So I think some kind of regulatory oversight needs to be brought in there as well. And finally, I think in terms of wastage is going to be eliminated surely by the amount of technology which insurance companies are deploying while processing claims, turnaround times, and so on. I think all of that will go away with digitization and automation and all of that. But I think the fraud portion needs to be dealt with a little bit more carefully. Yeah.
Can you elaborate on the soft fraud and the hard fraud that you mentioned?
Yeah, so when I spoke about hard fraud, I just said that it's absolutely a case of cheating, right? I mean, there's nothing there. I have seen in certain cities that the hospitals don't exist. They don't work, but probably they were registered 4-5 years ago during COVID times. A lot of these hospitals sprung up, and they don't operate anymore. But bills are coming from those hospitals. So I think those are typical cases of hard frauds. Soft frauds, which in our parlance, I mean in insurance parlance, we call it as overbilling or इंश्योरेंस है तो एडमिट कर दो, इंश्योरेंस नहीं है तो आउट पेशेंट में ट्रीटमेंट हो जाएगा. वो सॉफ्ट फ्रॉड्स, those are the kind of things. There's a long laundry list, I don't want to get into that. But I think this is an area that we have to deal with, yes.
Okay, coming to Mr. Karthik, you represent Novo Holdings as a pharma, as an investor in healthcare companies, pharmaceutical companies. How do you kind of identify, the FDA part of the businesses, and how do you deal with them? Like, are they the red flags? How do you weed out those red flags? Can you elaborate on that?
Firstly, thank you for having me here, and I do want to acknowledge that this is very differentiated and distinguished panel, and I think only Dr. Vikram and MediAssist could put us all together, because while all of us have different viewpoints, at the end of the day, all of us are trying to ensure that the average Indian gets the best quality healthcare he or she deserves. So, firstly, thank you for having us here. In terms of, from an investor standpoint, I think the answer on fraud is pretty simple. It's black and white, right? When we do diligence on a healthcare asset, or any asset for that matter, if we uncover something which is against the letter of the law, or even in certain cases the spirit, we will not invest, right? We will make sure that we stay away. And we've been fortunate. We partner with Manipal. We partner with Dilip Jose. We know that there are assets and there are people in this country who want to do or provide better healthcare. And as responsible investors, we help them grow. There have been instances where you have hard fraud in different ways, which gets uncovered when we do our diligence. And in those scenarios, we stay away. And even in scenarios where there is a question, I think we will not want to put capital behind that, because the view is there is enough and more to be done in the right manner in this country, and there's enough and more to be done the average person gets it in the right manner. I think that's how we look at it from a fraud perspective. I think from a waste perspective, at least from my view, it's more on the efficiency. So I think even today, in spite of the fact that we have large hospital chains, good hospital chains, even within them, I think even Dilip will agree that there is potential to improve operationally. And so how can we help them do that? So by doing that, you're reducing the costs, you're ensuring that you're able to pass on some of that to the end customer. But our systems and processes need to improve. We don't have as good a digitized system as you have perhaps on the financial side, as you have in healthcare. And as that develops, it'll improve. But even if you look at the process flow, there's a chance that someone might be prescribed the same test twice. And it's not because of malintent, it's just because the doctor wasn't aware or didn't have the process in place. So once we invest in a company, we tend to work quite actively with the firm and then help them through that process. And that helps quite a bit because eventually it does help. Yeah, we are investors who are looking to get returns, and eventually those returns go to our foundation. But the idea is that if you do it correctly, you then manage to benefit all parties involved, the customer, the hospital, and us as investors.
And how do you kind of deal with, so do you see more instances when you're scouting for the right investment opportunity? Do you see more instances of fraud or waste or abuse?
But because we are so focused on healthcare and because we are very deep in the sector, I mean, we have the relationships and the network, right? So we use that relationship and network to understand how a potential investment has performed or the softer elements of that investment as well. So I would say that if I look at, I've been investing in the country now for almost 15 years. If I look at what was happening 15 years ago versus now, we've come a long way. We've come, and even between investors, there's a dialogue which says, similar to what was mentioned, if there's a hospital or if there is a particular entrepreneur who is not as trustworthy, you wouldn't necessarily back them. So today I feel much more confident that you're able to keep aside the bad apples when you're looking at investment ideas. That being said, you can never let your guard down, right? So I think the point around fraud is non-negotiable. The point around waste is more operational efficiency, and there we can help from our perspective. Abuse is not something that from our perspective. Said obviously it matters a lot, but to the extent we can manage it, we do. But I think it's more on the first two for us.
Right. And there's a huge incentive for doing this fraud, waste and abuse because of the entire cost of healthcare going up. That itself becomes an incentive for players or for parties or for vested interests to kind of come in to that. So let's address the pricing of it, like the inflation part of it. So Mr. Singh talking about NHA, talking about Ayushman Bharat, the PMJ rates, that is something which is always a bone of contention between the hospitals and the government. The hospitals say that it's not enough, and government is like, you might as well do it in that. And in all this, the patient actually expects a good quality care. So how do you kind of fix those rates? How do you get the semblance right and ensure that the patient is treated?
The rates, package rates, basically under PMJY, they are dynamic. They have been changed to market needs and assessment. I mean, the real utilization pattern, the insights from market, the clinical evidence is all put together. So that is an ongoing exercise at NHA. And we have, while there are teams who do a lot of data crunching and provide the insights, and on other side of it, there are experts, clinical experts, renowned experts who provide their inputs, and we decide the rates. And precisely due to this, you will find that for all 1941 packages, we have revised rates during this period. Once, in some cases, more than once. And almost every year we are benefit package. Regarding quality of care, I mean, how we are ensuring, so that is inbuilt basically. There are 2-3 things. We are standardizing the processes basically. More than 670 procedures we have issued the standard treatment guidelines, which reduces the clinical variation, during treatment, the variations we spoke about, which minimize the possibility for abuse. And this list is increasing. In package design itself, if a hospital is having some good certification, is in alignment to some good, standard, they get incentive. Packages like a hospital having NABH certification of certain level will have, they can earn to 25% higher. So quality of care inbuilt is inbuilt in the perception. I'll definitely say the perception that rates are lower. Probably that may be true for some part and some chains, but may not be entirely true. If you go and see, I mean, from my personal experience, I'll visit a hospital who is running purely on PMJY patients. They did not complain and they are good. I mean, for a place like Jammu, that place, they were a good hospital. We constantly receive feedback that due to PMJY, we have to understand that health seeking, behavior amongst the vulnerable section has increased. Now they have that confidence to approach the hospital. And at many places, the inflow has increased. The volumes have increased. And so they can manage with these rates as well, ma'am.
Sir, there is another perception and even reality that corporate hospitals generally faces the payments from these PMJ treatments. They don't come on time. Like there's a lot of backlog for payments which are not released by the governments. And that has actually resulted in many corporate hospitals actually reducing their institutional business. So how do you kind of see that the payments are becoming prompter?
So this issue is in very few states, ma'am, because there are states which are clearing the bills in 7 days. They are prioritizing now. I mean, even the average, if I am not wrong, the average debt for bill clearing is, there are many states which are able to prioritize their health needs and are able to provide their share, because this is a scheme which is which has been financed jointly by state and center in certain proportion. Many a times delays do happen that when state is not able to prioritize their share, but having said that, I'll say delayed payment issue is at very isolated pockets, not everywhere.
Mr. Joshi, how about medical inflation? Insurance companies are also kind of pulled up for that premiums are being raised because the insurance companies have to pass on the medical costs that they bear from the hospitals. So how do you deal with that? How do you expect that? How do you kind of ensure that patients are comfortable paying those premiums and that leads to penetration of insurance policies more?
So medical inflation actually is a reality. It is true. And though consensus has not been there yet because the government data, I was pointed out by one of very senior government functionaries that medical inflation which you are quoting here in your complaint actually is not correct. It is far less. It's not true. So I think now at GI Council, one scientific study is being undertaken to prove that. And the reasons are many. One of the reason which I can see is, the first thing will be the rising customer aspirations. So earlier it was, the medical treatment was looked at as a very noble profession for the doctors or the healthcare providers, and the patient also was expecting only a basic type of basic and clean and sufficient amenities, enough amenities only. They were not looking at the comfort or the luxury. But of late, with the corporatization, luxury hospitals now. So some of the corporate hospitals in big cities are charging more than the 7-star hotel rates.
Hospitality rather than hospitals?
Yes. So in the maternity wards, the birthday party, when the child is born, so even the parties are they are not satisfied with the general ward. Initially they wanted a private room, and they wanted a deluxe room, and then they wanted an air conditioned, and then they wanted a suite. So customer aspirations also have been more. Secondly, because as I told, corporatization is happening, a lot of investment is coming. So many people who are actually not from this profession, but they are investors, they are businessmen. So they are investing in this. So their motive is profit making. It is not charity only. It is not charity only, and they want to make profit. So everyone wants to maximize the profits, and then some of the hospital chains are even listed, so they have to give value to the shareholders also. So this is also creating a pressure. Another reason for inflation is that backed by the customer aspirations or the aspirations of the few who are rather more vocal, I have seen that even the regulator or the government authorities have brought in regulations which want more and more inclusive health insurance cover. For example, as I told you, initially it used to cover everything. Sum insured was the only limit. Later on, to curb the costs, to inculcate some discipline, like what percentage of the total cost should go to the room rent. You have to pay, surgeon fees is necessary, medicine is necessary, but do we have to spend the entire money on the room rent? So some limits were introduced. But going forward, when many things were included in the coverage compulsorily, as I told you during that earlier conversation, insurance by nature is cover fortuitous things. Fortuitous things means it can happen, it may not happen. But now, sometimes the laws and sometimes the regulations are forcing the insurers to provide coverage for pre-existing diseases which are already there, people who are born with diseases or having permanent ailments are supposed to be covered under insurance. So there will be regular, definite expenditure on that, because it is required to be compulsorily covered, and then more and like migration and portability guidelines have been also been liberalized. So insurers are required to cover the sick people even one makes entries, even the fraud or if the misrepresentation was declared, witnessed later on, was proven later on, but by regulation you are supposed to carry them on. So many such things. When the costs are going up because of all the combination of these reasons, so naturally the costs will go up. And another big reason is that there is a regulator for insurers. So like I told, there are regulations. For TPAs also there are regulations. But for till date, for health insurance, for the hospitals, there is no regulator. There were some attempts like Clinical Establishments Act was promulgated, but it could not be implemented. There are no standard treatment protocols. And there is no clear-cut mechanism for finding out the reasonable and customary prices. So everything is vague, and that is why there is a lot of friction between the healthcare provider and the insurance companies. Healthcare providers think that the insurance companies are capitalizing and trying to reduce the cost, though the actual costs are really more. And the insurers think that they are wanting to just to maximize their profits, and that is why they are trying to get more and more. So all these reasons are there, and the solution to this is not in one person's hand. So he must, like my fellow colleague, fellow panelist here pointed out. So if there is a waste or if there is abuse, it's a national wastage. It's a national waste, and these resources can be used for better purposes. That is why there is a need for collaboration between all the stakeholders, amongst all the stakeholders, and then we have to sit together and find a transparent, fair, and a participative way of managing all these things, so that this healthcare need of the society can be provided in the most efficient and cost-effective manner.
Mr. Dilip, what would be your response to the points that Mr. Joshi made? Because at the end of the day, when medical inflation hurts, it's something that, hospitals are immediately looked at, that you are the source of the treatment. So how can you control that cost?
On several things that Mr. Joshi talked about, I agree with him. I think the first thing that we all have to understand is we are part of the same ecosystem. Whether we are a payer or a provider or an investor or a patient, we are part of the same ecosystem. So therefore, we will either swim together or sink together. I don't think there is a survival which is individual. One sector would survive or one segment would survive. That would not be a long-term kind of a situation. And as far as the quality is concerned, the question on inflation, should appreciate delivering quality healthcare is going to be expensive. Unfortunately, that you can, for example, you can run a hospital with qualified nurses or trained nurses, people who are not qualified as a nurse, but you pick up and sort of give them on-the-job training and all that. There is a significant cost difference. You could have technology which would make a difference for the patient in terms of recovery rates and outcomes and all that. The crux of the matter is, Kiran, that all of us unfortunately think about hospitalization on an episodic basis. That, the patient comes, get admitted, goes out, what happens to the claim or what happens to the payment is the matter that we end up discussing. As a system of healthcare in India, we do not track patient long term. For example, if a patient has come to my hospital, had a transplant, a renal transplant, and gone back, do we track him or her over the next 8 to 10 years what happened? Is the transplant still patent? If everything is still working, we do not. Because we don't, I'm not talking about Manipal, I'm saying we do not as a country, as a healthcare ecosystem, do not track that. We are oriented to episodic care and episodic treatment. I think till the time some of these fundamentals are sorted out, that, I know it's a long journey. We would only look at things from our perspective. Like Mr. Joshi said, a hospital would look at from the economic viability of a hospital. Similarly, like Anand said, they are also accountable to stakeholders. Like there are listed hospitals, we are not listed by the way, but there are listed hospitals, there are listed insurance companies, So the pressures would be there. So I think the way forward is for us to understand patient is at the center of everything, and can we move on to more holistic, more value-based care rather than episodic care. Those are the areas that we should explore. And honestly, I don't think it will happen during my career. My career span. It is a 20-30-year journey that we are talking about. This is a system which has been in place for over decades. There are ingrained players and interests in this. If we have to transform it to something new, it is a journey of several decades. But unless we begin it, it will not happen. Unfortunately, the current environment, all talked about suspicion. Unless we break that, it's not going to head anywhere. That's unfortunate.
Here I would just ask you one more thing that he mentioned about corporatization. We also saw in the last 10 years of the medical inflation really becoming worse. There has been this whole investment that has happened in the healthcare sector. A lot of foreign investors have come in. Has that kind of in any way influenced medical inflation, or how can it improve from here?
No, so I do not have had an experience of an investor influencing medical inflation. That when an investor comes into any enterprise, whether it is a hospital or an insurance company, there is an economic rationale, which is underlying. But I don't think it translates to doing something untoward for your consumer, whether your consumer is an insurance buyer or a consumer is a patient. And the larger fact, Kiran, is that, like Mr. Joshi said, consumer aspirations are increasing. 5 years back, no patient or family complained that your Wi-Fi is not working, because I could argue, no, you didn't come to my hospital for internet. But now, without Wi-Fi, we get negative reviews, and insurance companies get negative feedback. So aspirations are changing. Mr. Joshi talked about suites and single rooms and 7-star or 5-star kind of requirements. I think these are all expensive investments. And let me give an example that as Manipal, we have 49 hospitals today. All the hospitals are networked. What it means is a patient who has gone to my hospital in Gangtok today can go to my hospital in Patiala tomorrow, his records would be available there. It substantially increases the patient's safety, because the doctor seeing him later, maybe 3 years later, would know his clinical history at the press of a button. It increases patient safety compared to you giving a written prescription. Should we not invest in it? If we invest in it, it raises the cost to the patient. Some of it is a little circular in argument, but till the time we and realize that we are all part of the same ecosystem, we would not head anywhere is my worry.
Mr. Roy, would you agree with the points made by Mr. Dilip?
Yeah, absolutely. I tend to agree with most of the points Dilip is saying, because see, at the end of the day, there is medical advancement, there is advancement in care, and it is only natural that patients will gravitate towards availing the the most advanced care available. And how are they going to finance that? They're going to finance that through insurance. Those insurance customers tend to go for the higher end of the care available in the city. So I think that's natural. But what is needed, I think, is the realization that in most insurance policies today do cover all modern treatments, robotics, drugs, and all of that. But I think what Dilip alluded to, and I tend to agree, is that a long-term value-based care is the model that we have to slowly gravitate towards, with more collaboration between the payers and the providers. Because keeping the patient in the center, how do we ensure that they get the best treatment, but at the same time they also get a better outcome? It should not be that specific episode that has to be discussed about. It's a long-term journey. And insurance companies are very well placed to collaborate with the hospitals, because most patients tend to stay with the same insurance companies for a long period of time. And so we know what kind of health journey that patient is going after that particular episode, maybe 5 years out, 10 years out. So there is a lot of scope for collaboration in this space. And ultimately that will help, achieving better outcomes for the patients. That will also help in better financial outcomes for both the healthcare providers and the insurance companies. I tend to agree, yeah.
But how easy is it collaboration? How easy it is to collaborate?
I don't think it is difficult. It is very easy. We do have a network of 14,000 hospitals. We are working with some of them very, very closely. We are looking at creating a network of, say, preferred hospitals, okay? And if we can have some, there is this discharge. What are the complaints that customers mostly have about insurance? That they're making me wait endlessly at the time of discharge. Why does that happen? That happens because there's no trust that, okay, I have to look at the bills, and the bills come, and then my, the processing takes 2 hours, 3 hours. Why should there be any discharge process at all? If I trust the hospital, and at the time of admission, if I have given an approval, they should be able to discharge the patient without even asking for an approval. That's the kind of relationship that we eventually want to move to. And we are talking to many of our network partners, and hopefully we'll get there sooner rather than later. But yes, that is the goal.
Mr. Karthik, as a global investor in healthcare services, does it worry you that India is facing medical inflation at the kind of proportion that we are facing? And, how do you kind of pick and choose your investments, looking at that concern? How do you guide your investee companies?
Sure. I think first thing I'll say is, if you look at, the most important thing is quality, right? So today, if you look at the quality of care that you could get at a Manipal or any good hospital is as good or better you would get in many international institutions, right? And you're getting that at a fraction of the price, right? From what you would perhaps get in the UK, US. A lot of people come to India to get their standard procedures done, knee replacement, hip replacement, at a fraction of the cost, knowing that they are going to get exceptional treatment, with or without Wi-Fi, right? But that's one thing we have to the system to getting us to that point. I think the second thing is, when we look at investing, we're not looking to invest at the highest price provider by any stretch of the imagination. We're looking to invest at someone who's providing the best quality of service, right? Because that's an area that we can't influence. I'm not a clinician. I can help on the operational side. I can help on the governance side. There are multiple other ways I can help. The focus is on, if the quality is there, right, then you can eventually improve on the operational efficiency to ensure that the inflation doesn't move up, at least your cost to serve. Because eventually, if my thesis is based on price increases, that is not sustainable. Right? So we're not. In fact, many times when we speak to folk, what we're trying to understand is, in the plethora or in the range of pricing, where does this hospital sit? And what you want to ensure is that if they are at the top end, in certain cases they are, that's because the quality or the equipment that they use, or there's something in it which is so unique or so differentiated that they have to do that to make the right pricing. But from an inflation standpoint, when you look at our thesis, that's not the main area. One thing I'll add to what the fellow panelists have said to combat inflation is to perhaps have better preventive care. And I think Qasim had alluded to that as well. What we don't do well as a nation is good preventive care. Because today you're looking at the episodes that Dilip is talking about, when you go to the hospital and you fell sick, or you really did not take care of your body, and then therefore you are having that incident, and then you're worrying about the amount of money you spend at that point in time. However, if you had, as a nation, if we had worked together to improve our health in the preceding days, you would not necessarily have that. And I feel like that is an area which also we need to focus on as an ecosystem. How do we improve preventive health, improve, exercise, diet, so on and so forth. Another example I can give from our portfolio companies is Cure.ai. So what they do is, through their scans, they're able to identify lung cancer at a very early stage. Right? So the advantage now is, if you're able to do that, your cost versus spending on, if you're detecting it at stage 3 or stage 4, your cost is significantly higher, right? And perhaps at an inflated level if it is, much later. Versus if you're able to prevent it now, you're spending much less. So I think that becomes an important element as well. Because if you're only going to look at it at the point of hospitalization, I mean, it's too late in many ways. Right? And so that's how we look at it.
It was a good point Mr. Karthik alluded to. I wanted to ask all of you that are you leveraging data, AI? AI seems to be having the panacea to solve all the problems. So are you looking at AI for further solutions in this regard?
Yes, ma'am. So, as my fellow panelists said, earlier we were having data but not very sure what to do. Then we were doing analysis in Excels and descriptive analysis mostly. AI has changed that. In past 2-3 years I have seen. Now at scale for 45,000 claims, approximately 45,000 claims submitted daily, I can find out that from the report, I mean every claim is having around 50-60 pages, reports, scan reports, medical images. I can find out if there is any duplicate document submitted. And it references all documents in my repository for past 7 years. I can find out if a duplicate X-ray report, forged X-ray report has been submitted. So we find cases wherein after a time lag or maybe some different hospital, same X-ray report, they are submitting only name at the bottom has changed. This could not have been, I mean, this would not have been possible without the help of technology. We have found out cases wherein one doctor performing complex surgery on a given day at geographically 200 kilometer far away places, which is
to monitoring. They are now able to keep those patients outside of an ICU. Predict any impending collapse. So it reduces the cost to the patient because they are not in an ICU environment. And wirelessly monitoring, using the data and AI to predict if somebody might have an.
Mr. Roy, anything? Closing remark?
Yeah, so we are lucky to be, having a lot of data over the last 20 years of our operations, and we have a very strong data science and data analytics team. So the two quick examples that we have already deployed is, one is that during claims processing, we have an auto adjudication model where the AI engines kind of approves the claim or rejects the claim in seconds. So that obviously enhances the customer experience to a large degree. In terms of underwriting also, we have deployed a lot of coming into different cohorts, and they have different workflows then in terms of underwriting. Some go for medical underwriting, some are issued as a straight through process, and so on and so forth. So I think these are the models that we have already deployed based on data. We are also collaborating with various partners, including MediAssist, to build some Gen AI engines. So now it's not about AI anymore; it's about Gen AI, and we are looking at that as a next phase of improving customer experience. Yeah.
Thank you. Do we have time for questions? Any questions? Cool. I think it was quite an insightful discussion. We had key takeaways, I suppose, is the partnership that we all talked about, collaboration that you all talked about, how to use data better, how to have mechanisms where you can increase the trust of the patient. And governance, I suppose many of you talked about regulator. I think somewhere the role of regulator or regulations do come into picture. So I think it's a... Thank you all. Thank you for listening.
Doc, may I have you on stage, please? Team, may I have the mementos? Thank you. Thank you once again to our panelists for those forward-looking insights. As we build on the conversation and continue our theme of health without borders, it becomes clear that solving India's fraud, waste and abuse challenge demands not only intent, but evidence, clarity and a united approach. To strengthen the ecosystem's ability to act decisively, MediAssist, in collaboration with BCG, has undertaken a dedicated study that goes deep into the very issues we have discussed today. This work, rebuilding trust, combating fraud, waste and abuse in system alignment and structural reform. This next segment is about bringing that knowledge to the industry. It's about giving all of us, insurers, providers, innovators and policymakers, a shared fact base and a practical blueprint to drive real change. With that, it is my pleasure to move into the presentation of the MediAssist BCG study, a step forward in creating a transparent, trustworthy and borderless healthcare system for India. Ladies and gentlemen, please join me in welcoming Swayam and Aditya as they present the key findings of this pivotal research that will help shape the future.
Good evening, everyone. We're here to represent the collective thinking of MediAssist and BCG as part of this year's report. Two key words in the report titled Rebuilding Trust and Ecosystem. As the earlier panel discussion highlighted, us as a nation solving for FWA as a problem. For the next 10-15 minutes, we'll walk you through, reflecting on many of the conversations that have happened, but more importantly, bringing a very structured way of how to think about the topic. Let me take a step back before we jump into this year's report. It was almost 10 months ago when, with Dr. Chatwal and some of us within BCG, we had initiated this journey of borderless health. You will see this was a very bold vision. Underpinning this vision, of course, was how do we move forward as a nation in terms of our health outcomes? How do we achieve the borderless health vision of insurance for all? And we had codified 5 key outcomes, which I draw your attention to this framework here versus the 100% challenge, which is 98 and 2. Now in BCG, we have this very classic framework. 90% of the cases, and this applies to health insurance as well, tend to be absolutely clean. We don't need to inconvenience our patients, our payers and providers do a stellar job. 8% of the cases, however, might have some anomalies, might have certain inefficiencies, both errors of omission or commission. And then there's finally the 2%, which is perhaps more patently and overtly fraudulent. So to reach the 100% ambition, what we will do today as part of this report is study how do we really make sure that the 90 don't suffer and the organizations, the payers and providers both benefit from efficiency in tackling the 8 and the 2. The context behind today's discussion, of course, is around medical inflation. The stats reveal themselves to be very, very difficult. India, as we know, with the burden of lifestyle diseases, as we discussed and Kasim mentioned, the non-communicable diseases are all going up. The problem is not just from pollution or a lifestyle. There's also a growing problem of medical inflation. As BCG, as we study this globally, this is hard data that we have collected with a lot of effort. Across the globe, as you see, medical inflation is rising. There are 2 very interesting stats here. The first one is the rate of the medical inflation, but You will also see below that, what's the rate of coverage growth for private health insurance? Now, across the globe, you'll see medical inflation is currently ahead of the rate as we contextualize it, which is out of pocket. This has to go down significantly. Today, it's almost 40%. As part of this program and as part of borderless health, as we define the ambition, how do we reach sub 20%? This is really where India, along with the collaboration of all of its component stakeholders, we need to choose and very concertedly move forward into one of these paradigms, and regardless of the paradigm, make sure that our citizens don't suffer with the out-of-pocket expenses. This is perhaps the most busy slide, but we need to talk about this. There's an anatomy to FWA, there's a dictionary to FWA. It manifests itself in different forms.
Minimal risk sharing between different stakeholders. The previous panel spoke about thriving together as an ecosystem and not living in an ecosystem where it is a zero-sum game. Everyone all of this ultimately translates in the form of multiple operational inefficiencies that led to the passage of fraud, waste, and abuse. However, there are two last barriers that lie at the heart of this entire piece. One is the legal framework, the legal deterrents around curbing fraud, waste, and abuse. And the second is a customer mindset that has sort of started accepting fraud, waste, and abuse. The moment a patient gets admitted to a hospital or a claim comes to an insurer, patients, consumers are usually prepared that there is some sort of fraud, waste, and abuse that will possibly hit them, possibly impact them. It is this mindset that needs a drastic change. It is this ability to question, to be able to ask the right set of questions to all stakeholders that will probably be at the heart of solving this problem.
Quickly delve into the solution. A problem of this magnitude requires us all to come together as stakeholders, but it also requires a toolkit. Through the report and through the experience of both the organizations, we've tried to put together how we as a country could tackle this. Typically, when we think about fraud, waste, and abuse, we start thinking about detection. We think about data technology, but the heart of it is the mindset shift. And we start from prevention. And only by moving upstream, we truly bring in preventive care at the center of how we treat our patients, and that in turn will lead to a lot more downstream benefits to the insurers. Detection is, of course, once the care has been provided, we will need to make sure that we have the right processes, the right technology enablers, the right interconnected data, which allows us to even flag and pass off the 8% risk cases or the 2% fraudulent cases are caught. That's not sufficient. We also need, as Aditya described, deterrence. Today, for example, if someone commits fraud on a health claim bill, the maximum penalty that can be levied is that the claim will be denied or the policy will be rescinded. Now that, as a cultural ethos, has also led to certain lack of deterrence in the country. We will have to address that together with the policymakers. While we move through this entire journey, right from prevention to detection to deterrence, at our aid are three very important things, which is where the crux of the work lies. The first one is standardization. Very important. And this is where together, for example, defining standardized tariff structures that allow flexibility to individuals but bring in predictability to the stakeholders, to the payers and the providers. That will be very helpful. Standardization would also mean elements like unified health scores. Imagine what bureaus have done to lending. Can unified health scores do to health claims and health insurance? We are at the cusp of a time where AI and Gen AI are extremely, extremely potent and powerful. They will become ever meaningfully so. We will talk about a little about this, how we can use AI and Gen AI within the context of FWA. And last but not the least, while we bring together a connected care system, we as a nation need to have much more relevance and much more adoption of the national health stack. It will bring in every touch point, every diagnosis, every treatment onto a common platform. Just breeding that transparency will eliminate a lot of the fraud, waste, and abuse. I'll just take a couple of deep dives and then we'll hand over to the next panel, but these two deep dives are very pertinent. The first one is around connected care. We heard about the vision of preventive care, but this is a very important graph. If you look at the crux of it today, the insurers, the payers are sitting in the far right. They're just focused on maybe 10 to 20% of the value. They are, at the end of the day, as the word is so limiting, just a payer. They're a payer for a care. But as you start moving further upstream, collaborating with providers, collaborating with TPAs, collaborating with industry, you can start moving towards better quality of care provision, which is where things like diagnostics, detection, and then eventually, if all of us are able to move in a system which is looking at prevention, we will actually move a lot of us towards population health managers. India as a country, of course, needs paradigm shifts like this. Some of these moves are already in the works in India. Many players are moving forward in this direction. There's a lot to learn globally along the same paradigms. And these ecosystems will be truly interconnected. So this is one of the key fulcrums where India's FWA problem can be tackled. The other big fulcrum, of course, is the advent of technology, AI, and Gen AI. This is how we as BCG like to think of the various tools and instruments with us. The human mind. The human mind has an analytical brain, the left brain. This is traditional AI. Our industry has been using traditional AI tools for a lot of use cases. It builds upon rich data that providers have, that payers have, and this has to be strengthened further. Elements that flag any natural fraud or potential waste use cases, elements around excessive treatments being prescribed, overbilling issues, or document tampering can be caught by traditional AI. So that's the left brain. If you think about what Gen AI is now powering us with, is the creative ability of the right brain. For the first time, we are now going to be able to take medical decisions. We are now going to be able to support medical decisions. We have already seen documented research where the most advanced Gen AI models already possess the reasoning equivalent of a medical grad. Soon there will be a day where our doctors are doing robotic treatments, our payers and providers are leaning on generative AI to help them adjudicate how claims should be triaged, which claim gets how much of value settlement. Together, both of these can come together to really support our problem at hand, which is FWA. Now, while this is the tools, what should we commit to as a group? And that's really why this entire Raksha Summit 2025 has been set up. We started with the sobering fact that today we have about 8 to 10% FWA. Now, that's a very strong drain on a country that's starved of resources, 8,000 to 10,000 crores of capital. Through these collective actions, through the better standardization of protocols, tariffs, bringing in technology, bringing in and leveraging India's health stack, our beautiful digital public infrastructure, can we move towards near zero by 2047? As we studied this and we simulated it, just the capital unlock can help drive penetration much faster. If 2047 was our vision, can this actually help spur that achievement by 2037 or 2042 at the latest? So we gain a year or a decade just from making sure we tackle the problem of FWA. This, of course, won't happen without all of us in this room. There's a very detailed call to action that we have laid out in the report. We'll not go through the specifics. But for each of the four stakeholders, the policymakers, the payers, the providers, and of course, last but not the least, us citizens, we will have to all act in concert and help India come out of this FWA problem. We look forward to the rest of the discussions, and thank you so much. Please do take the time to go through the report and look forward to the next year's agenda as well. Thank you so much.
Swayam and Aditya, if I may have you on the stage. Team may have the memento speak. Thank you once again for the powerful presentation. What we have gained is not just insight, but a sharper lens on what needs to change, and more importantly, how. It's clear that the journey from health without borders is real, on-ground impact will only happen when we break down silos, trust the data, design with empathy, and collaborate with intent. And then brings us perfectly to our next segment. If the BCG study shows us what must change, this panel here to help us understand how the ecosystem can actually make it happen. Because the future of healthcare access will not be built by any one stakeholder. It demands hospitals, insurers, digital platforms, corporate health providers, and intermediaries all working as one connected system. This next conversation is designed to do exactly that, to move us from insights to action, from isolated workflows to integrated systems, and from transactional care to continuous data-driven health management. Ladies and gentlemen, welcome to our panel discussion on From Silos to Systems, Driving Access Through Data, Automation, and Mobile. Today's panel brings together leaders who represent every critical node of India's healthcare value chain, hospitals that generate clinical insights, insurers that enable financial protection, digital platforms that democratize access, and brokers who often hold the ecosystem together. Together, they will help us decode how India can move toward an interoperable, mobile-first, and customer-centered health ecosystem. And we have an exceptional panel to unpack this, starting with Dr. Ashutosh Raghuvanshi, CEO of Fortis Hospitals, representing the clinical engine of the ecosystem where data originates and care decisions begin. Shikhar Malhotra, CEO and Vice Chairman of HCL Healthcare, a leader in technology-enabled, integrated, and preventive care. Amit Ganorkar, MD and CEO of Tata AIG, bringing the insurer's perspective on breaking data silos and driving intelligent automation. Sarabveer Singh, CEO of Policy Bazaar, the voice of digital democratization and mobile-first insurer access. Mayank Batwal, CEO of Aditya Birla Health Insurance, championing wellness-linked, wearable-driven, behavior-based health ecosystems. Arvind Ladha, President of ACE Insurance Brokers, representing the integrators who bridge corporates, insurers, and providers. Last but not the least, and to steer this panel forward, we have Nikhil Chopra, Chief Business Officer at MediAssist. Thank you, Nikhil. Over to you.
Thank you, Shivani. Good evening, everybody. It's truly an honor to be here this afternoon and moderate this very interesting panel. I must start by saying how delighted I am to be part of this conversation, especially with such distinguished and a diverse panel, representing the best of best in the industry. Also extremely excited about the fact that very rarely does one get the opportunity to ask these set of people questions given the role that I play at MediAssist. So I'm most excited about that as well. I think conversation is very pertinent with respect to the idea of this discussion. This morning, and some of you all were here, the conversations and the discussions were predominantly around the fact that if healthcare and insurance has to move in a direction where members are at the center of the universe and sustainability and trust has to be formed, every stakeholder cannot be working in silos and separately. I think one thing that came out very clearly was the fact that it's not an issue of intent. Everybody is working in their own ways, but it may not necessarily be in the most collaborative manner. Given that, maybe Dr. Ashutosh, I'm going to start with you. Hospitals like Fortis sit at the center of this ecosystem, both a care provider and a critical data generator. How do you see hospitals contributing to building interoperable systems that make patient data accessible yet secure?
I think before I come to your question, I want to just make a general statement. You said that, the different stakeholders. I think we all are here for one stakeholder, and that is the patient. Other than that, I think there is a common purpose. So you said very well that intent is there, but, we are facing a lot of issues as a
we can give good, clean data to insurance company saying that these are the characteristics of the customer, then they are in a better position to price that customer, and hopefully, everything else will follow. Because one of the points from an insurance perspective is that despite having a very good product, I believe that the health insurance product in India, retail health insurance, is an awesome product. But there is a very high degree of skepticism. There is concern that whatever is being sold to me will not come true. Because, we are selling a promise. And at this point, we only take money, we are only, something else will happen later. I think getting rid of that skepticism is one of the key issues that we are faced with. And the report that you are referencing, we basically showed that by having proper procedures and processes, which include, asking the customer to fill up the proposal form themselves, explaining to them why, it's important to disclose, verifying that information again through an independent person. Because you see, the salesperson will always have a slight incentive to not, ask for everything or to avoid mentioning certain things. So we say that an independent person should do that. And finally, no conversation is complete without AI today. So, we use AI to get whatever was said on the call, and we make sure that that is present in the proposal form. So if it's not present, we ask that customer again, and we verify that. So I think our partners, so that our customers can have a wonderful experience, as in when they need to use this. Because that's really the key to growing this industry and to growing our own business.
Thank you, Sabir. Changing gears a bit, Mayank, coming to you. Question that I have is, how can insurers and providers together use automation and data to move from a transactional claims model to a more continuous health management model, in your opinion, Mayank?
Good evening, and thanks, Vikram, and the entire Mediasys team for this opportunity. I think, Nikhil, before I get to the specific answer, the first question that we must, and as a health insurance company and as health insurance, we always think about is that what is the business that we are in, right? And I think to some extent that conversation happened, and Dr. Raghuvanshi started that by saying finally it's the patient. Traditionally, because the health insurance industry has been part of the financial services industry and seen as a player, I would personally like to, and as at least in our organization, we want to challenge that thinking, because are we really in the business of money, or are we in the business of health? And I think that itself completely changes the way we look at this business. To our mind, yes, we have a financial leg to our business, but if we kind of rephrase our business as being more as part of the, and maybe at the intersection of financial services and the healthcare industry, then we look at our role as a very different. Are we just to pay the claim? Is that what our role is? Or is there an opportunity to play? Finally, what does a consumer want? Is there any consumer who says, hey, I want to come and take a claim from you just because I have bought a policy from you? No, except where it is, let's say, preventive care, at least in the traditional way how health insurance is looked at. No one wants to do that, right? Therefore, if you flip and say, is there a way that we can participate in the process of creating a better health outcome for the consumer, which is what I heard Dr. Raghuvanshi say, I heard Shikhar say, I heard other colleagues also say, then all of this becomes even more important than what we think. And so I think that's the first thing that we must seriously look at, and look at whether we need to kind of change the way we think about insurance as a category. Now, in that context, the role that we will have as, let's say, an insurance company, and in your question, what can we do together with the hospitals to make this more a continuum of care rather than just an episodic relationship? I think we have a long way to go. Our joint venture partners come from deal with, unlike in India where even at 15,000 hospital network that we have within our company, it feels we aren't having a right network. There, 95% of the claims, not just hospital claims, but also pharmacy, doctor, diagnostic, are paperless, but more importantly, humanless. Yeah? In our case, at least till a year back in the industry, and now many of us have moved, bit of a distance there. Even 0.95% will not be, even 1% will not be in this category of both combined, paperless and humanless. So, therefore, from a patient or a consumer perspective, who's finally at the middle of this whole ecosystem, everyone trying to kind of make sure that the experience of the patient is right, towards the right outcome, we have to seriously think at what is coming in the way and what can we all do to make that happen. Because therein lies friction in everything. Friction in experience, friction in, from a cost perspective, friction in relationships, right? Where whilst each one of us, I'm 100% sure each one of us are trying to do our best, whether it's the hospitals, whether it's the, distribution fraternity, whether it's the, health tech, to the extent that they are participating in this whole payers, something is not working out. And I think that's where we have to find a way to make that happen, it's a long answer to what must happen, and we can talk about it, of course, in more detail, and I don't think so right now we can get into that in the interest of time, but we must do that. The second one is that finally creating a better health outcome is the objective, and leveraging that data that can be, that can emerge from creating a more seamless way to kind of make sure that this whole relationship works. Of course we must do it. I mean, is our interest served if the consumer is not getting the right care and finally is not having a health outcome? Because we'll repeat, I'm sure facilities like Dr. Raghuvanshi's, Shikhar spoke about preventive, etc. All of us do want to create a right outcome, because that's what is the business that we are in. So I think there's a lot of work to be done. Some step being taken in that direction between stakeholders and at a larger level. But I think we need to seriously think about what can to make it happen.
Absolutely, and I think just extending what you said, Mayank, I think the other piece is that if this is something that you truly want to pursue, there's no magic wand which is going to change overnight. It's something that has to be pursued over a period of time with significant amount of investment in terms of time and money around it. And that lends me to you, Arvind, in this journey. Even the fact that you are, or you and your other constituents essentially play the role of customers supporting some portion of funding these efforts in the long run. How can brokers leverage analytics to move beyond placement? About also comes from customers wanting to put their money for a long-term outcome, which is really impactful.
Thanks, Nikhil. Glad to be here. I think my belief is that actually, just to take perspective, in terms of health insurance, I think this industry has really grown remarkably well in the last 20-25 years. I don't think any industry has grown at this scale. And health insurance is there's a lot more that we can do, and there are models that we can allude to. There are attempts that have not succeeded to the extent that they could. So we must just take a little credit for the journey that we've been on, right? As far as the role of brokers in terms of helping, I think both customers understand what they are buying. And I think of customers at two levels: the corporate that's buying the insurance and the consumer who's using the insurance. I think it's important to think of both these constituents. because the behavior of both these constituents will influence how the customer purchases the product and how the ecosystem underwrites the product. So brokers have played a significant role in analyzing data. That's also possible because the quality of data has started to go up. Okay. I don't think we've yet reached a point where the level of trust of the customer is high enough for them to want to fund any more because they are not very clear of the outcome. We do see customers who have a little more clarity about the outcome, who are clearly ready to put more money on the table. Maybe as an industry, we have to think of how can we give the customer who's, like you rightly said, funding part of this whole evolution, more trust, more comfort, and how can we get customers to lock themselves in? As an industry, most respectfully, I'll say that even we are not 100% sure of whether the customer thinks of us as partners or they also think of this as a transaction. And as long as we don't move from being seen as a transaction to a partnership, this back and forth will go on. But I do think that we are on that journey, and hopefully over the next many years, brokers as one of the catalysts will continue to accelerate this journey where we can see more funding coming, and then all of us feel more comfortable to raise the stakes in the game to get to where we know we can go to.
Thank you for that, Arvind. Coming back to you both, Amit and Mayank, I'm going to pose this question to both of you all. From your perspective, what are the key barriers still preventing interoperability between hospitals and TPAs and insurers? And what collaborative frameworks could help address them from your perspective? Post that, Doctor, I'm going to come back to you to get your perspective of what the issue is in terms of being able to collaborate. Whoever would like to go first.
So, firstly, Ahmed, so there are international models, like there are exchanges, there are pipes in between which actually do this job. One step towards that was the recent National Health Claim Exchange. I know that there are platforms like, that even Mediassist, kind of partner with, and there are other platforms in that. So it has to be through those independent pipes, and there should be not one, but there should be 3, 4, 5 such pipes which actually help do this. So that I have one integration to do, just one, and I do that integration as an insurance, as an insurance company, and then that all the providers have one, integration to do. That is how it should happen. The second one is data. Today, if again, I'm sorry, I'm referring to the South reference just for in the context of setting a reference point. Every data there is coded in international standards, whether it's ICD, PCS, whatever are the line codes, etc. Every, including pharmacy, including consultation, including diagnostic. We'll have to find a way to move towards that. I'm sure there are the Indian health information systems, etc., which at least the bigger hospitals are using. I'm sure that it is being happen. How does that data flow in that? Because if data flows in that, lots can happen. Experience, but also usage of that data. Amit referred to absence of data. We struggle, at least in my company, we invest in converting every data point that comes, even whether it is through, PDFs or wherever we get data directly through integrations now. It is a cost, right? It's to my mind, it's a wastage, because that data is probably available in the healthcare system. How can that move in that format to us? And then we work. Even with TPS today, like I know that with Mediassist, all the data now comes to us in standard coded. Is every TPA doing that? No. Whereas regulation itself says that when you pass on the data to insurance companies, you must have, you code that in ICD pieces. I think both availability through seamless integrations, converting that data into a format that it is usable and for that particular incident, and for creating longitudinal data for future reference. To your previous question of continuum of care, these are very important things, and we have to start that journey right now to really make sense. And I was also very, very excited about this whole initiative of ABDHM. Somehow it hasn't really got the pace that most of the other DPIs in India have really, in the way they have moved. I do hope that that picks up steam, because that will then create even another layer of longitudinal health data for consumers, of course, with consent, etc. A lot of usage can be done right from underwriting, but more importantly, the longitudinal continuum care that finally is important to create the right health outcomes.
So I think, Mayank has made excellent points. I, kind of agree with him completely on this. One dimension that I would want to add is, and I said that, the first point is about alignment. I think in the entire value chain, or in the entire chain that is, operating in healthcare, we all need to, everyone is today jostling for owning the customer, right? I think somewhere we need to solve that problem, right? And here I think, again, a great point that Mayank made is basically some sort of a consent architecture will essentially solve it, because finally the data is owned by the customer, right? And I think we need to have that, format, because, we need to have some, architecture for that data to be shared with, consent, etc. Otherwise, today, the entire ecosystem is basically jostling for ownership. And I think that is the alignment problem that I'm talking. So first, I think conceptually, all of us need to be aligned. And, the customer is co-owned by everyone. And, then we, look at data, etc.
Thank you both for that. Doctor, can we get your views on what you consider to be the reasons why there is a asymmetry of data exchange that potentially takes place, and what issues you face?
No, I think very important points made, all very valid as well. And I completely agree with that. I think the barriers from the hospital side is that people will have to invest in technology, which is an hindrance. But most hospital groups are investing quite heavily into technology. The problem comes with the smaller providers, and how would they be able to create that infrastructure? And that is, I think, one of the biggest barriers in my mind. The second point I would like to make is that the interoperability is extremely important. And as Mayank said, there has to be some kind of a pipeline. You can't expect, 50 insurance companies and 2,000 hospitals to be able to come to a common kind of platform. I think that's something which has to be driven by policy. And I think that is very, very important. Unless that happens, I think we will not be able to create a seamless journey for the patient, which is very important. I think if we even create the primary health care modules across the country, which the government is trying to do, that data is not really flowing into anything. So the ABA IDs, which some private healthcare providers do provide, so we give an option to every single patient, and there are very few people who opt for it. So we will have to probably come up with policies where such things become mandatory, and there is a longitudinal journey of the patient where the data, of course, is controlled by patient. It belongs to the patient with all the necessary, safety measures in place with the data protection, etc. I think this is the way forward. And I strongly believe actually that this is the first step if we want to create a system. Today we are operating in a kind of a Wild West atmosphere. Everybody, there is some lab somewhere, there is some diagnostic center somewhere, there is some hospital somewhere, and there are insurance companies, and it's just not a system at all. So I think in order to create a system, I think it's very, very important this first step of putting the technology piece together is done. If that is done, 90% of the other problems
Shikhar and Arvind, appreciate your patience. I'm going to ask Sarbir one more question and then come back to you all. Sarbir, given what the three gentlemen just spoke of, I see you you meaning Policy Bazaar, as the bridge. You partner with both Tata AIG and Aditya Birla, from what I know. You need data from hospitals. What, according to system? Is it integrating with EMRs? Is it using your filter advantage to create universal health risk score that all your insurance partners can use for real-time underwriting? What is it that Policy Bazaar is intending on doing?
So I want to make 2 points. First of all, we've been at it for 17 years to digitize the insurance industry, and I think we've learned a few. So 2 things I want to tell you, that it is never the data or the technology which is the problem. It is the incentives which are the problem. And we have seen this across the world, that if you look at EMR as an example, while we can say whatever we like about it, truth EMR models in the world, except maybe in smaller geographies or cities like that. It is an inherently hard problem, and to expect a country like ours to solve it at scale, in my opinion, is not possible. So what we feel is, what we have learned along this thing is that you have to align the incentives correctly. Today, just as a small example, between insurance, we have been on a path of aligning incentives. And what we have seen is that as we go down that path, the data flow, technology automatically improves. The technology is a servant, not the master, right? So I believe that going to be the solution. I think the solution is going to be to align the incentives. And what, you may say we are very naive in healthcare, because that is definitely true. But I think we have taken a view that we have to get this alignment in place, right, for this thing to become bigger. Because we can always wait for things to happen, or we can try to jump in ourselves. And with our initiative called PB Health, we have started a journey where we want to link the chain together, where the incentives for the hospitals are the same as the incentives for the insurance company and the distributors, such that the consumer can get a good experience, right? And I think that technology, everything else will follow. And if we are able to align the incentives, and truly a hospital will make money by not, admitting a patient, or the OPD care provider will benefit from not actually referring somebody to IPD, right, and screening correctly, etc., then the data and technology will follow. So it is our experience that is the tail, not the head of the problem. So what we are trying to do is to say that, look, let's jump into this, set up some facilities, show that this is possible. And if we can show that it's possible, then we work with more like-minded people and try. Because what we believe is that without the alignment of incentives, there is no way that this system can ever work. Because then people will be at cross purposes, and it is very hard to say that if somebody is incentivized to do something else, that they will do something for the glory of the country or of the citizens, or whatever the story is. So we don't think that's going to happen. And we believe that we have to, take whatever we have. We've been trying to do it in our own way in the insurance ecosystem. Now we want to take it to the healthcare ecosystem and try to link it. Maybe it will work, maybe it won't. But that's kind of where we are headed. Yeah.
Thank you for that, Saragbir. Shikhar, a question to you, which is again a little more future, from a future perspective. Do you believe mobile and wearable-based health data will meaningfully integrate into insurance and the provider ecosystem in soon? And what needs to happen for that to scale? I know Mayank, as he mentioned, his joint venture partner, and they do a lot of work around the whole piece with wearables and using that data. What do you see, and what is your view of it happening in India?
I think it's certainly doable. The question is, what will they do with it once it's done? Because, like I said, we have a rainy day mindset, so it's episodic, right? So when we are looking at a rainy day cover, so we've designed it as an episode. But we've taken the same mindset to preventive health also. So we said prevention is also an episode, so you do one annual health check. So that also becomes an episode. Whereas in reality, prevention is every day, every minute. Today you decide to skip dinner because you've eaten a lot, that itself is prevention. So I don't think we've got to the point where we fully understood how all these things will actually get integrated and what we'll do with it. But most certainly it can be done. But I just also want to point out to, everyone on this panel, let's give the devil its due. I think as far as prevention is concerned, India is at an all-time high of, in terms of awareness, in terms of action, all those things are actually certainly moving in the right direction, right? I can't even think of an employer today that's looking to optimize or control budgets on prevention health. So there's a clear motivation to do a lot more. And I think that motivation, if it's harnessed through the question actually that you asked, which the access to the data is certainly there, access to the wearables that are there, but I think we've got to think of actually what will we do once that is there, because that part of it hasn't really been given enough thought. And so how do you really incentivize someone? Today, preventive health expenditure, and let's be very honest, it's a bit of a grudge expense by everyone, right? Whether it's by the insurance or whether even by the individual also. Very few people see it actually as really that kind of an investment. If that was the case, it wouldn't be so low. There would be considerable sort of budgets. Everywhere else in the world, it's given a lot of serious thought. It's given adequate budgets because they do realize, a stitch in time saves 9. So that mindset will come. And I'm not too worried about it because I think incrementally, and I think everyone has very nicely added that it's an evolving process. So mindset is growing, experiments will happen, and I think everyone should be experimenting a hell of a lot more because something will stick, something will not. You learn from that, experiment more, and I think it'll all move sort of in the right direction. A little bit thrust by the government on prevention wouldn't hurt either. I did read that the Karnataka government was planning to roll out mandatory health screenings for all white-collar employees. So, that will bring a sea change of things once those things become law as well. But yeah, absolutely, I think that we should be looking at both, not just the connectability, which we have the capability to do that today, but what will we do with it and how will we incentivize people to look after themselves?
Fantastic.
Can I just add to that? I think it's possible, and if I can share our experience, you can play a role in that, even as an insurance company, which traditionally was never thought so, right? I'll give you concrete data last year. Last year, even after the consumers bought the policy, right? Normally you do what is called pre-policy medical checkup, etc., and it's seen as a friction, and then when we want consumers, adult consumers, actually we were able to nudge them to the right incentive mechanism, which was one of the themes that when you drive behavior, you would have the right incentive mechanism, which Sarvi was talking in a different context. If you put the right incentive, 35% of our consumers actually went in for some kind of a preventive health assessment. You have to create the right kind of frictionless process. Second thing was, because of that process, and then the right incentives, because it was not just about a checkup, there was other steps that came in. More than 9% of our consumers got some benefit for good health behavior, which was driving some good health behavior, versus about 6.5% for bad health event. So I think if you create the right model and create the right incentives, it is possible. The question is, you have to rethink the model. What is the business that you're in, and then start finding ways, whether it's designing the offering, designing the right incentives, and of course then work with the ecosystem. And we didn't do it ourselves. We did that with a host of health providers who finally helped us made it happen, whether in the digital health space or in the physical health space. It can happen if you want to make it happen.
Absolutely, and very recently we've started, as MediAssist started our journey with HCL Tech, and we've been working very closely with Shikhar and with their teams. And for me, I think it also goes back to that point of intent and, like Shikhar said, what is it that you're going to do with the data, how you're going to use it. So very clearly in our attempt with HCL Tech, access to that data and the investment that that organization has put in to be able to consume that and use that in terms of what they are actually doing as a program gets created. So it was very fascinating for us to be able to see that at close quarters. So I think, like you said, Shikhar, it's about getting the data, consuming it, and utilizing it for an outcome which is impactful, that actually makes a lot of sense. Arvind, my last question, and then I'm going to close. the discussion is how can we ensure that data-driven automation doesn't dehumanize healthcare, but instead enhances empathy, trust, and access. And just before you get in, if there's anybody else that would like to also answer this question, because I think it is important after Arvind does, please feel free.
I think we must distinguish between an interaction with a human and a human interaction, right? I think currently we interact with humans, but do all patients feel that they get a human-like interaction with a healthcare provider or a health insurance provider? I am not 100% sure, right? I think some of them would maybe rather actually deal with the machine, right? That is more accurate, less emotional, and does not pass off its burden to the patient. I believe very strongly that actually technology will help humanize the interaction, because humans basically will try to use technology to give a better experience. Everybody wants a satisfied customer, right? As organizations, as enablers in the ecosystem, we have to think of how do we enable the healthcare provider to use technology without feeling threatened, to use technology to think of how they can provide their customer better care. And any satisfied customer is only likely to come back and consume more of that service rather than less of that service. I think of this as a very positive initiative, and I think I'm very hopeful that it will work out well.
Anybody else would like to add to that? Fantastic. So firstly, thank you, gentlemen. It was absolutely lovely interacting with you. I have personally learnt a whole bunch. And I will go back into my avatar very soon of coming and answering questions and not asking you the questions. With that, I think if there's one common thread to all the perspectives today, it's that access is no longer just about availability. It's about connectedness. The shift from silos to systems will require shared data standards, mutual trust, and more importantly, the will to collaborate beyond commercial boundaries. That's where real transformation will lie. With that, thank you once again, gentlemen, and appreciate your time.
Thank you to our incredible speakers for that powerful exchange. It is inspiring to see how technology and intent are finally coming together to deliver healthcare that is faster, fairer, and more inclusive. This discussion underscored the breaking silos across data, systems, and stakeholders is key to unlocking true success. By aligning on trust, collaboration, and smart use of data, we move closer to a seamless health Without Borders future. And on that note, it's time to celebrate those very champions who are driving this transformation. Across hospitals, insurers, digital innovators, brokers, global benefit leaders, and women trailblazers, there are individuals and institutions who didn't just adapt to change, they accelerated it. They broke silos, pioneered new models, built trust, and proved that healthcare can be human, intelligent, and accessible all at once. These are the people the industry looks to for direction. These are the people who set the standard for excellence. These are the people who we honor tonight. Ladies and gentlemen, it is now my absolute pleasure to introduce the Raksha Awards 2025, a platform that celebrates the best of data innovation, digital transformation, customer centricity, global benefits leadership, and the outstanding women shaping the future of healthcare. The Raksha Awards have become a trusted symbol of integrity and aspiration, a movement the entire industry looks forward to because it recognizes not just achievement, but impact. So let's celebrate the leaders, the collaborators, the innovators, and the change makers who embody the spirit of health without borders and are shaping a stronger, more inclusive future for all of us. Let's begin the Raksha Awards 2025. We begin the Raksha Awards 2025 with our first honor of the evening, the Precision Insights Award. This award celebrates the extraordinary power of data, the ability to transform raw information into insights that sharpen decisions, fuel innovation, and elevate outcome across the industry. The nominees in this category have demonstrated mastery in predictive analytics, and data-driven execution that has reshaped business performance and customer impact in the MediAssist world. We will start with the category in insurer. These insurers have used analytics to strengthen underwriting, pricing, risk management, and service delivery, creating more personalized experiences and more efficient operations. The nominees are Bajaj General Insurance, National Insurance Company, Go Digit General Insurance, the Oriental Insurance Company, the New India Assurance. And the winner for this year is Go Digit General Insurance and the Oriental Insurance Company. May I please have the representatives from each of the insurance companies to be on stage, please, to receive the award. Satish, Nikhil, and the jury who has actually worked on deciding the awards. So while everybody walks in, I would like to go ahead and mention that there is an independent jury which decides the Raksha Awards, which actually works towards in establishing that. This year's jury includes Amit Prakash, GM Health TCS. We have Sushma Anupam, and then we have GS Srinivasan from Galaxy Health Insurance. Please welcome Amit if you are around. It would be nice to have you on stage. Sorry, I think he's not been able to make it. Satish, Nikhil, if you could do the honors. Next up on the same category, we have the broker category. These brokers have used data to deepen risk understanding, provide sharper advisory, and deliver more tailored solution to their clients. The nominees are Marsh India Insurance Brokers, Prudent Insurance Brokers, Aon Risk Insurance Brokers, Willis Towers Insurance Brokers, Plum Benefits Insurance Brokers. The winners, and there is a tie in this category, and we have two winners. May I have, the winners are Prudent Insurance Brokers and Willis Towers Watson. May I have the teams from the organizations be on stage to collect the award, please? Thank you, Pawan. Doc, may I have you on stage as well? If there is a representative from Willis, it would be nice to have them on stage, or we'll send the award. Wherever there is no representation, we would be sending the awards across to the organizations. Next up in the same category is the employer. These employers have leveraged data to optimize benefit design, strengthen cost efficiency, and enhance employee well-being. These companies have applied data-driven insights in strategic planning to ensure that their employees get the best of this structure with lowest cost. Nominees are Interglobe Aviation, Tara Consultancy Services, Morgan Stanley, Ernst & Young, JP Morgan Chase, Kyndryl, and Infosys. Any guesses? Okay. And the winners are Interglobe Aviation and Infosys. We have a tie there as well. Both. I don't think we have. Our next recognition celebrates digital transformation. The organizations reshaping how health insurance are delivered through the power of technology. We start with the insurer category, and the nominees are Star Health and Allied Insurance, SBI General Insurance, the New India Assurance, United India Insurance Company, Neva Bupa Health Insurance, Manipal Cigna Health Insurance. And the winner in this category is Star Health and Allied Insurance. Any representation from the, I thought the team was there. I think they have left. Nikhil, why don't you join us on the stage? Moving on, in the broker category, these brokers are leading the way in adopting AI, automation, and intuitive digital platforms. Nominees are Prudent Insurance Brokers, Loop Insurance Brokers, Policy Bazaar, Plum Benefits Insurance Brokers, Onsuring. Any guesses? This one, I think. Okay, none. Okay. The winners are Plum Benefits Insurance Brokers and Loop Insurance Brokers. Both have shown how digital leadership can transform engagement and service delivery, and it would have been, I think I have somebody walking up from Loop. The next up in this category from a stakeholder perspective is hospitals, where we all are looking forward to digital transformation. Nominees are a wildcard entry, Dr. Agarwal's Eye Care Hospital, Manipal Hospitals, and Jupiter. One winner is Manipal Hospitals. If I have somebody on stage from the team, it would be good. Manipal has demonstrated remarkable innovation in creating a connected digital-first care ecosystem. The award honors those who place the customer or the patient at the heart of every decision. And in the insurer category, the nominees are Aditya Birla Health Insurance, the New India Assurance, the Oriental Insurance Company, Bajaj General Insurance, Universal Sompo, and Cholamandalam MS General Insurance. I think all of us have been seeing it for the last couple of years. Aditya Birla Health Insurance and Cholamandalam MS General Insurance. May I have the teams on the stage, please? Moving on in customer centricity, in the broker stakeholder category, nominees are Marsh India Insurance Brokers, Edme Insurance Brokers, Anand Rathi Insurance Brokers, Policy Bazaar Insurance Brokers, Aeon Risk Insurance Brokers. No surprises there. Prudent Insurance Brokers and Marsh India Insurance Brokers. Both the organizations have demonstrated an unmatched ability to understand and anticipate customer needs and deliver on the same. Thank you, ladies, for joining us. Moving on in the same category to the employer stakeholder, the nominees are Tata Consultancy Services, Cognizant Technology Solutions, Qualcomm, Microsoft, Titan Company Limited, Hindustan Petroleum Corporation Limited, and Honda. Winners are, again we have a tie in this one, Capgemini and Hindustan Petroleum Corporation Limited. These organizations' employee-first philosophy has created a benchmark in personalized health support. Thank you for It would be nice to have some claps, guys. Thank you. I know it's evening and we have taken the whole day. Thank you everybody. Congratulations. Moving on to the hospital category, nominees are Max Healthcare, Sir H.N. Reliance Foundation Hospital, and Aster DM Healthcare. Winner has exemplified patient-centered care through responsiveness and I think the team is left. We'll move on. The next award category honors organizations reimagining how benefits are designed, making them more flexible, holistic, and human. Starting with the insurer category, the nominees are Aditya Birla Health Insurance, the New India Assurance, United India Insurance Company, ACO General Insurance, Tata AIG General Insurance. Winners are, any guesses on this one? This is the innovative benefits architecture. Okay, so from a MediAssist perspective, from a corporate standpoint, it's New India Insurance Company. May I have somebody on the stage from the team? Yes, thank you. Outcomes. Moving on to the broker category, the nominees are Prudent Insurance Brokers, Marsh India Insurance Brokers, Edme Insurance Brokers, Beyond Risk Insurance Brokers, and India Insured Risk Management and Insurance Broking Services. The winners are Marsh India Insurance Brokers and Aon Risk Insurance Brokers. This award acknowledges those who provided innovative benefits and elevated industry standards and demonstrated real, measurable impact for employers and members alike. May I have the Marsh name? Yes. Moving on to the employer category, the nominees are HSBC, Tata Consultancy Services, Citibank, Intel, JP Morgan Chase, and Salesforce. Winners are, and this was a tough one and a difficult one, it's a tie between Tata Consultancy Services and Salesforce. May I have the organization representatives on stage, please? These organizations have redesigned benefits to meet the evolving need of today's workforce, combining flexibility, data-led decision-making, and a deep commitment to employee wellness. The next category is Employer Excellence in Health Benefits Award. This award recognizes organizations that demonstrate exceptional commitment to employee well-being through innovative, inclusive, and forward-thinking health benefits programs. This award honors employers who go beyond traditional benefit structure to create meaningful impact, improving health outcomes, increasing engagement and participation, and fostering a culture of care and support. Nominees are Citibank, HCL Technologies, Infosys, Dell Technologies, and Cognizant Technology Solutions. Winner is Cognizant Technology Solutions. Congratulations, team, for the winner who's redefined employee well-being through progressive, high-impact health benefits. Insurer category, the nominees are ICICI Lombard General Insurance, Devabupa Health Insurance, Tata AIG General Insurance, Air Health Insurance, Reliance General Insurance, HDI Global Insurance Company, Freedom Health. And the winners are May I request the representative of the organization to come on the stage, please. In the broker category, this award recognizes a broker that has transformed the global benefits landscape through innovative design, deep market insight, and outstanding service delivery in the global market. Their ability to simplify complexity and enhance the member experience sets a new benchmark. Nominees are Marsh India Insurance Brokers, Lockton Insurance Brokers, Howden Insurance Brokers, TrueSure, Aon Risk Insurance Brokers, Willis Tower Watson Insurance Brokers. And the winners are Aon India and Marsh. We gave a reason to Simon to come back on stage. Mike and Nick, if you're in the, why don't you join us? Nick and Mike. Sorry, they're just coming in. If, gentlemen, you can wait for us 30 seconds. Sorry, that was an afterthought. Moving on to the employee category, this award honors an employer that has successfully designed and implemented innovative global benefit solutions, aligning business objectives with the need of diverse workforce. Nominees are Tata Consultancy Services, Wipro, HCL Technologies, Tech Mahindra, LTI Mindtree, and the winners are Tata Consultancy Services and HCL Technologies. Next up is Innovator in Wellness and Preventive Care Award, something that we all have been valuing from morning. This award honors a true innovator in wellness and preventive health care whose programs and solutions have created measurable improvements in holistic well-being and long-term health outcomes. The nominees are MediBuddy, MFine, Visit Health, Beacon Care, Connect and Heal. And the winner is MediBuddy. If the team is there, if they want to come on the stage with Emba. Thank you. Next up, while it is an award category, however, there are no nominations and there are no winners. Everybody who's participated is a winner. It's Women in Healthcare Benefits Award. This recognition honors a woman whose dedication and leadership have significantly contributed to strengthening the healthcare benefits ecosystem. Their work has inspired progress, collaboration, and positive change across the industry. I would start with Shanai Ghosh, CEO, Zuno in General Insurance. I'm not sure if somebody is there from the team. Moving on, Chella A. Kumar, GM, National Insurance Company. I think ma'am's not been able to make it, so please. I think ma'am was not able to join, but she has sent something for us to listen to. Ma'am, all yours.
Small thank you message from National Insurance Company, General Manager Tella ma'am. MediAssist has achieved a remarkable progress since its inception in June 2000 as a third-party administrator. Also, we must express our appreciation for the wonderful and the innovative technical initiatives undertaken by your TPA. The advancements you have made in this area are truly impressive, and we are sure these initiatives will pave the way forward to even better and faster claim settlements and fraud prevention. Your journey so far and your unremitting efforts and dedication is truly appreciated. This is a commendable initiative taken by your team, and I wish your entire team continued success and prosperity in all your future endeavors. All the very best from National Insurance.
Thank you, ma'am. Moving on, we have Kasturi Sen Gupta, ED, New India Insurance. Ma'am's also not been able to make it. We have a representative to collect the award. We have Smita Srivastav, ED, New India Insurance, as the next winner. Next that we have is Tulsi Naidu, Chief Executive APAC and Group Executive Zurich Insurance Group. I think she's traveling. Niharika Singh, Executive Director, IFCO Tokyo General Insurance. Alda Dhingra, Vice President, International Business, Prudent Insurance Brokers. May I have somebody from the team? And thank you. We have Prabha Chokhani, Head of Broking and Placement, Willis Towers Watson, Insurance Brokers. As the next winner, okay. And the last but not the least, Dr. Ritu Mittal Garg, Chief Growth and Innovation Officer, Fortis Healthcare. If there's someone from the Fortis team, no problem, we'll send those across. Thank you. Your leadership in shaping the next generation of healthcare transformation is truly appreciated. Once again, a heartfelt congratulations to all our nominees and winners tonight. Your work doesn't just move the industry forward, it moves the healthcare ecosystem forward. Thank you, gentlemen. And on that note, it's time to celebrate, Ladies and gentlemen, as we draw the curtains on Raksha Summit 2025, I want to extend my heartfelt gratitude to every speaker, partner, and participant who made today so impactful. This summit has never been just an event, it has been a shared mission. And today, each of you has contributed a voice, an idea, and a commitment that will shape the next chapter of India's healthcare journey. Across the sessions, a few themes have echoed with remarkable consistency. We heard that India's healthcare transformation will rest on 3 pillars: trust, technology, and collective intent. From strengthening data integrity and addressing fraud, waste, and abuse to embracing health jam and pioneering new models of care, the discussions today have reminded us that progress is not a solo act, it's a collaborative responsibility. Most importantly, we came together around a shared belief that we are capable of building a health system that is faster, fairer, and more inclusive, one where customers move through their care journey without friction, confusion, or limits. A system that truly lives up to the promise of health without borders. Thank you for your energy, your insights, and your unwavering commitment to this vision. A special thank you to all the partners, our distinguished speakers, our moderators, our guests of honor, and every participant who stayed engaged through the day. Thank you, Doc, for being on the podium and handing out the mementos. Thank you for that. Your presence elevates this platform and inspires us to keep pushing boundaries year after year. And with that, we officially conclude Raksha Summit 2025. But the evening is far from over. We invite you to continue the conversations, make new connections, and unwind together. Drinks and dinner. Please join us as we celebrate the spirit of collaboration and the future we are all building together. Have a wonderful evening, ladies and gentlemen, and thank you once again for being with us today. Thank you.